This lesson is about AI that supports clinical diagnosis rather than replacing it. You will look at three areas where that support is already real: medical imaging, laboratory analysis, and generating differential diagnoses. You will also learn how to judge an AI suggestion critically, because knowing when these tools perform well and when they fall short is the skill that actually protects patients. The short version is this: AI is very good at spotting patterns across huge volumes of data. It does not examine a patient, it does not know a patient's history, and it does not carry clinical responsibility. Everything that follows sits inside that frame. Treat the output as one input among many, and you will use these tools the way they were designed to be used. Medical imaging is where AI has made the most measurable clinical impact, and the reason is simple. Images are data-rich, the patterns can be subtle, and the volume of scans keeps growing faster than the radiology workforce. Imaging models are trained on millions of labeled images. A chest X-ray model, for example, learns from datasets where radiologists have annotated findings like nodules, pneumothorax, or cardiomegaly. The model learns those patterns and can then flag them in new images. Notice the wording carefully. These tools do not make a diagnosis. They generate alerts and highlight regions of interest for the radiologist to review. The interpretation and the decision that follows it stays with the clinician. As of 2025, the FDA has cleared over 900 AI-enabled medical devices, and radiology is the largest category. Viz.ai analyses CT angiography and alerts the stroke team when it detects a large vessel occlusion, reducing door-to-groin puncture time by 20 to 30 minutes. Aidoc flags critical CT findings, including pulmonary embolism, cervical spine fractures, and intracranial hemorrhage, then reprioritizes the radiologist's work list so urgent cases are read first. iCAD ProFound AI assists breast cancer detection in mammography and tomosynthesis, reducing false negatives while maintaining specificity. IDx-DR detects diabetic retinopathy from retinal images and is one of the few systems authorized to make a screening decision without specialist review, built for primary care. AI is advancing in pathology and dermatology too, but those tools are less mature, so apply more caution. Large language models are increasingly capable of generating differential diagnoses from a clinical scenario. Research in journals including JAMA Internal Medicine and Nature Medicine has shown that models like GPT-4 can produce differential lists that include the correct diagnosis at rates comparable to, and sometimes exceeding, physician-generated lists in controlled studies. If your organization permits it, you can use AI as a thinking partner for complex cases. Start by presenting the clinical scenario: symptoms, history, labs, and imaging findings, using de-identified information, never protected health information in a non-compliant tool. Then ask for a ranked differential, then challenge it. Ask it to explain its reasoning, consider alternatives, or account for a new finding. The real value is as a checklist, making sure you have not overlooked something rare. Now, the limits, and these matter more than the capabilities. AI can hallucinate medical information. It may cite studies that do not exist or describe diagnostic criteria incorrectly, so always verify against trusted sources like UpToDate, Dynamed, or the primary literature. AI does not examine patients. It cannot assess how someone looks, palpate an abdomen, or pick up the subtle cues an experienced clinician notices at the bedside. AI also lacks longitudinal context. It does not know your patient's history, their social circumstances, their preferences, or how their presentation has changed over time, and performance varies by condition. These models do better with common conditions that have clear diagnostic criteria, and noticeably worse with rare diseases, atypical presentations, and multi-system disorders. AI supports diagnostics in the laboratory too. Automated blood smear analysis classifies blood cells and flags abnormalities, cutting manual microscopy time. Sepsis prediction models analyze vital signs, lab values, and nursing notes in real time to predict sepsis hours before clinical recognition. And in genomics, AI speeds up the interpretation of sequencing data to identify pathogenic variants faster. That brings us to a common misconception. AI is not replacing radiologists. Imaging volume grows 5 to 8% a year, while the workforce grows 1 to 2%. AI helps absorb that gap by handling routine screening and flagging critical findings. So radiologists can focus on complex cases and clinical consultation. The same principle holds across specialties. AI does pattern recognition at scale. Clinicians provide judgment, context, and care. So, how do you use this responsibly? Never rely on AI alone for a diagnosis. It is one input among many. Document your clinical reasoning and note appropriately if an AI tool contributed to the workup. Stay current because these tools are updated often, and you need to know what the current version can and cannot do. And report errors. If a tool misses a finding or generates a false positive, send it through your organization's channels because that feedback is what improves the system. Now try it yourself. Take a de-identified or textbook case and work through the 4 steps. Present the scenario, ask for a ranked differential, challenge the reasoning, then use it as a checklist. Do it right now in the interactive prompt playground on this lesson page at FreeAcademy.ai, or paste your case into an AI assistant like ChatGPT or Claude.